Hello and welcome to another edition of Professor Speaks. My name is Alex Fernandez. Alongside me, as always, Dr. Craig Stern. And Happy New Year! We hope you had a great New Year and a great holiday season and didn't get the flu like some of us did, myself. And Which should also be a good healthcare topic for the upcoming season too. But we'll move on. I digress. We have some fresh new healthcare topics for you. Something we're gonna go over some of the things to look forward to in 2018 and beyond. As a society, we're continuing to progress in patient care with new technologies, some affordable solutions, and more efficient methods of patient care. So, Dr. Stern, if you would please enlighten us, what can we expect in the aging population and somewhat the millennial population with regards to healthcare and their rising healthcare costs?
Yeah, big topic. We'll never handle that topic in a couple of minutes. So let's see if we can narrow. First of all, Happy New Year to everybody. I hope it's a healthy year for all of you. Certainly for us as well, since the staff has been hit with some flu. Let's talk in general about, we have really two topics. One is the aging population and the other one is the millennial topic. We have a personal kind of debate going on here because we have millennials who don't want to be hit with being the reason for all healthcare change. By the way, you're one, so you know, as much as you criticize.
I think we got a bad rap.
Yeah. And the other part is the aging population. Let's deal with the aging first. It's easy to kind of group the aging population and say, well, they're the cause of all the healthcare use, all the healthcare cost, etc. That's kind of simplistic in order to deal with it because we have a whole population of people born after World War II that are in that aging population. They have what is known as pre-existing conditions, but in fact they're chronic diseases.
Right.
Those chronic diseases, if you look at it as a population, kind of focus on a few that are very common. Diabetes, hypertension, hyperlipidemia, also known as metabolic syndrome, and then a host of other diseases. Well, the way to approach this, the way to handle it with regard to cost, the traditional argument has been the following. One, try and move as much of the brand into generic because the generic costs about a fifth of what a branded drug costs.
Yeah.
In the case of specialty drugs, try and move the specialty into biosimilars, which is a similar kind of argument of decreasing it.
Right.
How much that it decreases cost, that's not quite clear. In Europe, it's about 15%. Here, it may be a little bit about the same or a little bit more, but the idea is that now that there are a lot of biotechnology products that are moving into their patent protection problems,
right,
that biosimilars are part of that solution. The other part of this is that the generic and the biosimilar issue deals with drug cost. And no question, that's the direct answer that people immediately go to. But the other problem has to deal with utilization. What does that mean? It means the number of prescriptions that people are taking. So the direct argument is go look for problems where there are duplicate drugs, where there are polypharmacy and there are drugs that people don't need to take anymore. So you can cut down on the total amount. Because even if a drug is expensive but you don't need to take it, then you remove that cost entirely from it. Okay?
Right.
But ultimately, the real argument, as we've talked about multiple times, is prevention. Now, it's easy to say go prevent it because clearly you want to make sure that people go to the doctor appropriately, that they use drugs when they need to, but they don't use drugs when they don't, that they're using other modalities of therapy. That's simple to say. There is a wide disparity across the United States in Appalachia, West Virginia, where we've done a lot of work, and in other areas across the country where we've also done a lot of work. We've seen a wide disparity of healthcare of people that can afford, not afford, or otherwise. At the end of the day, the real key to all of this is to try and improve nutrition, improve exercise, improve diet, weight loss, etc. Now, it's easy to say, but it's certainly a lot easier to give someone who is pregnant to ensure they have a prenatal vitamin with folic acid to try and reduce the risks of spinal disease, of problems with autism in older people who get pregnant, etc. So prevention, prevention, prevention. But the other part of this, as the argument, and then I'll stop without going too far in trying to deal with a very complicated, very involved argument, is
You only ask the hard question.
only ask the hard question. Is the therapeutic guidelines. Therapeutic guidelines have been designed by literally every one of the major national groups on healthcare, whether they're cardiology and the American College of Cardiology, American Heart Association, or American Rheumatology Association for arthritis, or whatever. In that regard, what they've tried to do is to say, here are the standards of care for which there is a lot of evidence that demonstrates that these therapies are going to come up with a positive response.
Right.
And so the idea is to try and get everyone to a minimum standard of care, and then if people can afford or can get other care, then clearly they can add to it. But the idea is to take everybody and get them to a minimum standard of care. And that's what the guidelines are about. That's what they're trying to do. So those are the major issues.
Right.
Lowering cost, lowering issues with regard to utilization and numbers of prescriptions, and then dealing with therapeutic guidelines to ensure the fact that people are getting therapy that hopefully is going to work. Those are the main arguments today of what goes on.
Right, and those arguments really go to all populations rather than just the aging population.
Yes, they do.
Because the millennial population now has more information, more information readily available for them for prevention than most of the aging population does now.
It does, and the millennial population is different. People keep bringing up issues about how they're different. I think the real issue that we need to consider is that there is more technology available, and millennials are better at adopting that technology. It's one thing to have it. It's like my mother, who I could never get to sit in front of a computer because she was afraid it was going to break if she did it. But millennials, on the other hand, grow up with it. They've learned about it. They immediately have it. My grandchildren already know what their grandmother's passwords are, so they can go in and play games on her phone and everything else. They've grown up with it. So the most important thing is adoption. What do you have? You have apps that help you for prevention, as you've talked about. You have apps that help you to, if you will, self-diagnose and self-treat. Now, there is a problem with that.
That's dangerous.
It's very dangerous, but for common things like a common upper respiratory infection or a urinary tract infection or something, maybe people think that they can deal with it. They don't have to go to the doctor. They don't have to spend money. But what millennials have gotten into is not just the technology, but also the issue that the retailization, as we've talked about in the past, is acceptable because they're not going to the doctor to have every problem observed and every problem evaluated and treated, but rather to deal with, I have one problem, I want a solution to one problem, I want you to deal with that, and then I'm going away. And if there's something else, maybe there's something that's involved in the pharmacy aisles that's over the counter, maybe they're interested in some other alternative medicine or herbal remedies, whatever they are. Yes, there's always a risk in it, but their concern is really focused on what's common is common and let's treat it. What's uncommon I don't know about, and I won't know about it until someone sees them and deals with it. And that brings us to the other part of it, and that is there aren't enough doctors now to treat every patient for every condition. There aren't enough specialists to treat every patient for every condition. And so the movement to mid-levels where there are more nurse practitioners, physician assistants, now in most cases pharmacists, to deal with a lot of these conditions, kind of adds to the total volume of physician extenders, if you will, that extends the reach of physicians to be able to deal with these problems. So that, if you will, you have triage that deals with a very sick patient that requires physician involvement. A patient perhaps that isn't as sick and more routine can be dealt with by some of the mid-levels in these physician extenders.
Right, and some of these things could also help cut down some of the wait times that
yes, absolutely.
society was finding to be a huge problem.
Absolutely.
But also moving along with that, with the technology and the advancing of technology, helping get more information out there, with the digitization of everything, could we expect a more efficient method of monitoring patients?
Well, we hope so. I mean,
Of course,
fundamentally,
yeah.
the idea is hope. That yes, you have more information, it's available, and what you're trying to do is to move away from the silo system where there's information in the pharmacy, but it's not communicated to everyone else. There's information in the physician office, not communicated to everyone else.
Right.
Information in the hospital, not communicated to everyone else. So the idea is to get away from the silos and move it to a coordinated thing where therapy is on for perhaps a patient's phone or a patient's mobile device,
Right.
and all that information moves with them as they go around the healthcare system, coordinating and bringing all that together. That's the hope.
Yeah.
The problem is that right now, a lot of that information is accumulating, but a lot of it is very poor data. As we see, for example, when we do our analytics, et cetera, is a lot of that data is not very good data. They have left out information. They have not included some information.
Right.
The information that they've given frequently is transposed, or someone has transposed information, and so the information isn't quite accurate.
Someone trying to read the doctor's handwriting. Yeah.
Well, part of the idea of having electronic is to get out the doctor's handwriting, make it electronic.
Right.
But the fundamental problem is it takes time. So hence the big move today to move from typing it out and putting it out to speaking it, to try and get it into the system. But even with that, it's short, and so we're in a transition period. We don't have the solution, but we're in a transition period. We're trying to transition from all of the data in the physician's practice, all of the pharmacy information, and then adding into it a patient outcome information, what's known as PRO information, all of this to try and bring it together. There isn't a simple, easy way of doing it today, but that's the move. That's the hope. That's what we're trying to do.
And the hope to get everybody on board with what kind of information needs to be in there, and yeah, totally understand. But now we got to look more into 2018 and say, are there any new technologies that we can be excited for the upcoming new year? We know about the digitization of everything, but that's kind of been accumulating over the years.
And I think we should talk more about that in future weeks.
Right, and we will. So, but moving forward, is there anything that we can expect to be excited about for this new upcoming new year?
There are some new therapies coming out for migraine headaches. We had some initial therapies that came out many years ago. There was a big improvement in what we were doing for migraine headaches, moving from just a pain medicine or some problems with barbiturates and opiates, which were not optimal treatment, to some newer drugs that have worked well for a group of people, but still a group of people that don't get treated. There are some new treatments on the horizon for migraine that should be a big improvement in what goes on for a subset of people with migraines.
Okay.
Number two is we have the problem, it's a huge issue, everybody talks about it, of antibiotic use, in that we have overused drugs for empiric therapy, meaning we don't have a culture that says this drug for this particular bug to kill this disease. And so people have done empirically treating with very broad spectrum stuff. And as a result of that, many of these antibiotics don't work anymore for common things. So there is a significant move to try and come up with new antibiotics to treat serious infections, and new ways of enveloping drugs so that they pass through and get by all of the resistance in order to try and deal with that. Now, separate to that, there's a whole thing in what's known as companion diagnostics, where there's genomic tests that effectively are looking and saying, does the person have this genomic particular problem for which this drug can treat it and be effective, or don't they? So you have a better way of telling whether a drug is going to work or not. Similarly, there are other tests that are coming out in companion to help us to guide that therapy and what goes on. And there are some significant cancer therapies now that are newer ways of going after cancer, with the move to try and not necessarily cure cancer, but to move it from a deadly disease to a chronic disease, and putting it into the standpoint where people will be treated on a regular basis. Having said that, specialty has come up with some new things with regard to cystic fibrosis, which is a horrible problem for young kids and others. So there's a lot of things to be excited about. The downside is that they're expensive, and national organizations everywhere have attacked the problem of how do you get this more into a competitive environment so that the costs are affordable, or there are other ways of financing it. Some people are now looking at letting people pay it out over time, or coming up with some financing mechanisms the same way that you would whether you're buying a house or buying a car or something
like
like
a
that.
30-year fixed rate.
It doesn't make it good. It
Right.
doesn't make it easy, but trying to find ways in order to try and attack this problem. Clearly, some will be governmental solutions, and many will look at how other countries are doing it
Right.
versus what the United States does it. But these are arguments that have to be addressed. You can't put them under the pardon me. You can't put them under the rug anymore, because they're too expensive, they're too important. People have to be able to get a chance to deal with it, and that's part of this issue of therapeutic guidelines. Can somebody be treated with a lesser, not perhaps a new drug, but it's an important step that they can get significant response or otherwise before, even as an alternative to some of these? That's the whole argument of what's going on.
And they can't sweep it under the rug because that population is increasing. That
Yes, it
sick
is.
population.
Yes.
And well, that's not something to look forward to. Trying to keep it optimistic here. But yes, there are some exciting new therapies coming out. Also, we've heard of some where computers or data collecting mechanisms are being implanted, and they work alongside several different therapies as well. So a lot of things to look forward to. We'll cover them throughout the year, and that's it for today. We will talk next week. Did we have a topic we wanted to mention to them? Go ahead, Em. You can talk. You're the producer.
We discussed the digitization of medical records and the potential security risks that come with that.
Right, the digitization. We wanted to talk more about that next week. So stay tuned. We'll come back next week. Next Friday, every Friday at noon, around noon. And we'll see you next week.